Hi, good evening friends. Welcome to the oral surgery live class from DBMCI MDS experts. I'm Dr. Himani Joshi. I'm a maxillofacial surgeon. I've done my BDS from Government Dental College and Hospital, Ahmedabad. Then I got an opportunity to work in AIMS, New Delhi as a junior resident, as a non-academic junior resident. Continuing with the junior residency, I was fortunate to be All India rank 6 in AIPG exam, which is the new NEET. And I've done my PG in maxillofacial surgery from Maulana Azad Institute of Dental Sciences, New Delhi. After that, I got into senior residency at Lady Hardinge Medical College, again in New Delhi. I served there for around 1.5 years. After which I cleared the SRship exam of AIMS New Delhi. I finished my senior residency from AIMS New Delhi and continued working there as a research associate or a pool officer. I was enough for me with government jobs, so I resigned from AIMS and now I have my own practice of maxillofacial surgery. I have my local procedures in my clinic. I am attached to various North Delhi hospitals for my general anesthesia cases. And I love to teach, which is why I am here today with all of you to learn this very, very beautiful, very thrilling subject, which is called maxillofacial surgery. All right. We'll just wait for 2 to 3 minutes for all your friends to join. And then we'll start the academic aspects of oral surgery. So basically, orthognathic surgery is the topic which we will start today, right? It is one of the most exciting, one of the most thrilling topics, but it is not a topic to which a BDS is exposed to, all right? Wherever you have done your BDS from, I mean, you must have seen patients who are going to go for orthognathic surgery, who are admitted in your wards, or who are the post-operative patients. But we are usually taught the simple aspects of orthognathic surgery, like maybe genioplasty or the basics of BSSO and leaf port 1 osteotomies and all of that. In a BDS curriculum, usually we don't dive too deep into orthognathic surgeries. But unfortunately, in the NEET and INI exams, a lot of questions come on orthognathic surgery. I mean, not just the theory, conceptual questions, not just the factual questions, but even the conceptual questions like, where the cut is given and where the segment will move and what are the complications, what are the indications. Everything is asked in so much detail. So I thought I should start the live class with orthognathic surgery, which is a very, very difficult but very, very interesting subject. All right, very, very interesting topic. All right. So what is orthognathic surgery? Orthos means aligned. What is the meaning of ortho? Orthos means aligned. All right. So you can all make notes along with me. And guys, this is a YouTube session free for all the students across India. I have my YouTube logged in my phone. So whenever, wherever anybody who wants to ask anything or you want to raise any doubts, I'm open for discussion. You can post your comments or your doubts in the YouTube link. It is just in front of me on my phone. And you can post your doubts or you can post anything that you're not understood, or if you want me to repeat it, just write it down. YouTube में chat section है, live chat section is open. आप उसमें जा सकते हैं. कोई भी चीज़ आप चाहते हो कि मैं repeat करूँ या आप नहीं समझ आई, तो आप उसमें पूछ सकते हैं. All right. So, what is orthognathic surgery? Orthos is basically means aligned. Okay. And gnathos is jaw. So orthognathic surgery means any surgery that is done to change the alignment of the jaws. All right. Like you can see here in this picture, this is a very, very straight facial profile, well-aligned maxilla, well-aligned mandible. The maxilla is in synchronization with the middle third, with the upper third face. The mandible is in synchronization with the rest of the face, and it has a pleasing straight profile. Okay, so the two things, that is function, which is chewing, swallowing, speaking, okay, all these functions of jaw, and cosmetics means appearance. In both ways, this is an orthognathic jaw. It's a well-aligned jaw. Whereas you can see here that if you start from the top, okay, the maxilla looks fine, the nose looks fine, the forehead looks fine, the maxilla looks fine, the mandible is suddenly very, very retrognathic. All right. So this is a skeletal class 2 profile due to mandibular hypoplasia. Okay. So I would want, the patient has a large overjet, a large overbite, if it is a deep bite, and it is difficult for him to chew. It is difficult for him to, articulate certain words. Okay. Chewing, speech. Sometimes the tongue function is not very normal. Swallowing is a problem. And of course, looks is a problem. The patient would want that, this is like a bird. I look like a bird. I don't want this chin to be so back. Please bring my chin forward. Or please, bring my jaw forward, especially in males. Slight class 3 profile is very, very preferred in males. So, the surgery that we do to bring the jaw forward and make it straighter, that is orthognathic surgery. Similarly, here you can see it's relatively normal maxilla, normal upper thirds, but a class 3 profile due to mandibular prognathism. And these are just few examples. It can be a mandibular excess, mandibular deficiency, maxillary excess causing class 2, maxillary hypoplasia causing a class 3 kind of profile. It can be an open bite. It can be a congenital deformity like, hemifacial microsomia, or some condylar hyperplasias, seen in puberties, trauma-induced facial malformations. So anything that is causing your facial profile to be functionally and cosmetically unacceptable, that is corrected in orthognathic surgery. So as a surgeon, it gives me the thrill of, it makes me feel like God, I am going to correct somebody's looks. I'm going to just cut the jaw, move it forward, and make him straighter, make his face straighter. It's a very, very thrilling feeling. Once I hope all those who love oral surgery, I really wish that all of you get oral surgery as a branch, as a PG branch. And then when you actually give that incision to, cut that bone and move it forward or take it back or correct the chin, and the post-operatively, when you compare the pre and post-operative pictures, it's a different thrill altogether, my dear friends. It's a very, very challenging but a very, very thrilling aspect of maxillofacial surgery, which we are going to talk about today. All right. So what are the indications? Why do we do these orthognathic surgeries? Okay. So like we discussed, it can be for cases which have congenital deformities. It can be for patients who have trauma-induced deformities. It can be for patients who have, ankylosis. So a child who's had a trauma in childhood, one side of the face has ankylosis, that side doesn't grow, the other side grows. So after he's become an adult, you have to correct the ankylosis also. And you have to correct the facial profile also. Because of ankylosis, there is canting of occlusion, there is, deep bite on one side, open bite on other side, gagging of occlusion, the occlusion is slant, there is no curve of SPE, everything is haywired. Okay, and so you have to not just correct the ankylosis, but you have to correct the facial features also, which is what we do with orthognathic surgery. Okay, so any problems, if they are beyond the scope of orthodontics. So this is a very beautiful envelope of discrepancy, which was described by Proff. and you've all studied it in your ortho lectures, that the innermost envelope is the corrections. They are the 2 mm, 7 mm, 4 mm, 2 mm retroclination, 7 mm proclination, 2 mm downward, 4 mm upward. These are the movements that are possible with simple orthodontics. Okay, the green envelope or the middle envelope, so this is just pure orthodontics. The middle envelope is the things that are possible with orthodontics plus growth modification. And if your correction is beyond that limit, okay, if the patient is already an adult, growth modification is not a possibility, and say you have to take your maxilla 15 mm advance, you have to advance your maxilla 15 mm. Of course, it is beyond the scope of orthodontics. It is beyond the scope of tooth movement to correct that, to do that correction. So, for that, we have the cut and paste orthognathic surgery, or we have what is called the distraction osteogenesis, which we will discuss in the later segment. Okay, so the outermost envelope of discrepancy is the possible movements of maxilla and mandible that can be done with orthognathic surgery. Okay, so OGS is the short form that we use for orthognathic surgery. All right. So just to describe the beauty of this beautiful surgery. So this is a patient with bilateral cleft lip and palate. All right. He's operated beautifully for cleft lip. He's operated for cleft palate. He's had his alveolar bone grafting and everything done. You can appreciate that because of the cleft palate surgery, his maxilla is hypoplastic. Okay, you can see that the facial profile is more or less straight except for the maxillary region, which is very common in patients with cleft palate, sorry. When you operate for cleft palate, there is maxillary hypoplasia. Okay, so this patient has a class 3 profile because of maxillary hypoplasia. Now, I will do my orthognathic surgery and correct this maxillary hypoplasia. Similarly, this patient has had burns. Okay, because of the burns in the neck region, everything is burnt. Now, what happens in burns is post-burn contracture. After burns, there is severe scarring of the soft tissues, and the scarring is so severe in this patient that it has, just taken the mandible outward. It has just pulled the mandible with itself, causing a severe open bite for this patient. His posterior occlusion is absolutely okay. Okay, but he has a severe anterior open bite. You can see his occlusion is straight, his maxilla is fine, his mandible is also fine, but just because of those scars, his mandible is just flared up like that. So, there is an anterior open bite which I need to correct by orthognathic surgery. Again, this patient, very, very normal patient, normally growing, everything is fine, but maybe when I see his profile, I can see that the maxilla is slightly backwardly placed and the mandible is slightly anteriorly placed. So, I correct his occlusion by orthodontics. I have a reverse overjet where the maxilla is behind, mandible is ahead, and now I will do my orthognathic surgery to take my maxilla forward, bring my mandible backward and give him a straight profile. Alright, similarly this girl, she has a vertical maxillary excess. There is excessive show of the maxillary teeth. She says, I don't like this excessive show. When I smile, all my teeth start showing. And I don't like this appearance. So I cut the maxilla. I take the maxilla up. My mandible auto-rotates with it. And I give her a beautiful smile. Alright. So many, many such examples. And this is the magic of orthognathic surgery. So this girl who has a, kind of protrusive maxilla and a retrusive mandible, I take the mandible ahead, I take the maxilla up, and this is the beautiful profile that can be created for her. Okay, similarly, the vertical maxillary excess that was there, I just cut the maxilla, I took it up, and this is the result. Okay, just 2 to 4 mm of incisal show, which should be there in a pleasing smile. And these are the kind of results you get with orthognathic surgery. Similarly, this boy, severe class 3 mandible due to maxillary protrusion. do a BSSO, take the mandible back and get a straight, handsome looking boy. Alright, so this is the things that we do when we talk about orthognathic surgery. Alright, so as soon as we see the patient, we don't directly prepare the patient for surgery. We don't jump for the surgery directly. There is a lot of process that is required when you plan an orthognathic surgery. Alright, so the process or the steps for orthognathic surgery are: first is assessment and analysis. You take the patient's pictures, you take the patient's occlusal impressions, you take the patient's bite, you make all the records ready. Then you take certain x-rays. Alright. The main x-rays that we do in a patient who is planned for orthognathic surgery are the lateral cephalogram and the PA cephalogram. Now, first of all, what is the difference between a lateral skull x-ray and a lateral cephalogram? When we say cephalogram, it is always ruled. There is always markings there, so you can do your measurements. Whereas a lateral skull x-ray is just, it can be magnified, it can be shortened, you cannot do measurements in a non-cephalometric x-ray. Cephalometric x-rays are measured, they are scaled. So you can do that, okay, maxilla is 3 mm behind, mandible is 5 mm ahead as compared to the anterior nasal spine or as compared to whatever landmarks you are choosing. So you can do measurements only on a cephalogram. So the main x-ray that we do for this orthognathic surgery is lateral cephalogram, and the analysis that we do on a lateral ceph, it is called COGS analysis. It is called COGS. COGS stands for cephalometrics for orthognathic surgery. Okay, so OGS is orthognathic surgery, C is cephalometrics. So cephalometrics for orthognathic surgery is the COGS analysis that we do in all the cases that we are planning for orthognathic surgery. Alright, PA cephalogram is done only in selective cases. Okay, it is done, the analysis that we do here is Grumman's analysis. It is the Grumman's analysis that we do. COGS is done in all cases. Grumman's is only done in cases where there is asymmetry. Only in cases where there is asymmetry. Suppose there is one half of the face is tilted upwards and other is downwards. Okay, asymmetric face. If you have to plan a case with asymmetry, you will go for a PA cephalogram, and the analysis that you will do is the Grumman's analysis. Alright. So the first step is you analyze how much maxilla is back, how much it should be, how much the mandible, where it should be placed, everything. Okay. Second thing that you do is you do your orthodontics. This is the pre-surgical orthodontics. Now, what is pre-surgical orthodontics? Nature is very, very, beautiful. God is much sharper than you and me, of course. All right. So, whenever the body is born with a deformity, nature tries to overcome that deformity by, camouflaging certain things. Okay. Suppose my maxilla is retrognathic, my mandible is protrusive. Suppose I have a class 3 profile. Okay. My jaw, if I talk about the jaws, my mandible or the lower jaw is forwardly placed and my upper jaw is backwardly placed. So in that case, like for example, this boy. Now in this case, what will happen is nature will try to compensate this by taking the lower teeth back and taking the upper teeth forward. The nature will try to bring the teeth into occlusion. The nature will try to compensate the defect by just changing the direction, changing the flaring of the teeth so that they come in contact and the patient can chew. Okay. This is called compensation. The nature has compensated for the deformity by, abnormally proclining the upper teeth and abnormally retroclining the lower teeth. It is abnormal for the surgeon. but for the patient, that is helping him to chew, right? So this is called nature's compensation. What we do in pre-surgical orthodontics is basically decompensation. Now, why do we decompensate? Because now that you will take the lower jaw back and you will take the upper jaw forward, this compensation will be wrong. It will make the teeth in opposite directions. Okay? And unsettled occlusion or a poor occlusion, if the patient has a poor occlusion, the surgery will never be successful. So the first thing that you have to settle is the occlusion. Okay? So pre-surgical orthodontics is done for dental decompensation. Means whatever abnormal flaring has happened to the upper and lower teeth, you take 6 months, you take 8 months, you take 10 months, whatever is the duration for orthodontics, and you correct that compensation which has happened. So whatever dental alignment is there, that will worsen initially, but after surgery, everything will come to normalcy. Okay? So I hope this is clear with everybody. So we do the pre-surgical orthodontics for the dental decompensation. Okay? I will give you one more example. If this is my upper jaw and this is my lower jaw in a class 3 position. Okay? So my upper anteriors will be excessively tipped anteriorly and my lower anteriors will be tipped posteriorly just to bring them into occlusion. Now decompensation is I will bring the upper anteriors to normalcy. I will bring my lower anteriors to normalcy so that in my orthognathic surgery, when I take my maxilla forward and I take my mandible backward, the teeth will meet in normal occlusion. That is the purpose of doing pre-surgical orthodontics. Okay? Third thing that we do is we do a mock surgery. Before performing the actual surgery, we perform a mock surgery or a practice surgery. It is not really for practice. Basically, you perform the surgery on the articulator, on the cast, or you can perform it digitally on the computer. And in that mock surgery, you do these steps. Okay, so when you have taken the upper cast, you have taken the lower cast, you have articulated it, you have fixed it on the articulator, and now you perform that surgery on the articulator. You cut that maxilla, you take it forward, cut the mandible, take it backward, and bring the jaws into occlusion on the articulator. Now, in that correct position of the jaws, you make something which is called as the occlusal splint or occlusal wafer. Now, what is occlusal splint or wafer? We call it a wafer because it is very, very thin. It is an acrylic plate which is kind of registering the bite of the patient once the jaws have moved into the correct position. Okay, it is basically an occlusal record of the corrected jaw position. So that when I'm doing my surgery, I don't have any guide. I can't really measure 3 mm, 4 mm, everything. So I will take a guidance from this occlusal splint. I will put the occlusal splint, and wherever my maxilla and mandible, fixed together in that splint, that is the correct position which I have pre-planned in my mock surgery. It can be done physically or it can be done in the computer. I will show you all the steps one by one. So don't worry, this is just for you to make your notes. I am broadly explaining it to you, all the steps. One by one, we will see all the steps. Okay, so just understand and make your notes here. And I will show you all the steps nicely. So after you've done your mock surgery, you have made an occlusal splint. You sterilize that splint into a cold sterilization, like, whatever cold sterilization is used in your institute, glutaraldehyde or whatever. And then you actually perform the surgery. Surgery is the easiest part. Just give an incision, cut the bone, take it forward, take it backward, take it upward. Just don't let the patient die out of bleeding. That is it. So surgery is really, it's not that easy. I'm just having fun. It's very, very challenging. Okay, maxillary surgeries bleed a lot. Mandibular surgeries need a lot of precision. So you learn, when you become a PG, you learn slowly, and then slowly, you are a master of it. Okay, so the next step is surgery, and the last step is post-surgical orthodontics. Okay, So in pre-surgical orthodontics, we have done the decompensation. Now in post-surgical orthodontics, you will just do the finishing, or what we call as the settling of occlusion. Okay, settling of occlusion means that 1.5 mm, 1 mm, that minor discrepancies, because however best your surgery is, it is not necessary that your teeth will come absolutely into occlusion. So whatever that 2.2 mm, 0.3 mm minor cusp for the relationship that you want, whatever your orthodontist has decided that I will give this kind of an occlusion for the patient, that post-surgically you can do that settling of occlusion, which is just a few weeks job. Okay. So these are the steps that we have to follow for every conventional orthognathic surgery. These are the steps for conventional orthognathic surgery. Now you will ask me, ma'am, agar ye conventional hai, so what is unconventional? Oh. This is the conventional orthognathic surgery जो हम बहुत सालों से करते हुए आ रहे हैं. From many years we have been doing it. These are the steps that we follow. So what is the problem with this? The problem is that this pre-surgical orthodontics takes around a year or a year and a half. And the patient who wants orthognathic surgery can be a little impatient. So he said, नहीं यार मुझे ortho नहीं करानी, तो मेरी surgery कर दो सीधे. Just do my surgery directly. I don't want any ortho. He doesn't understand that, you know, surgery cannot happen without dental correction. But for that, for such cases, for such selective cases, what has come up now is the surgery first approach. There are specific indications. Not every case can go for a surgery first approach. In those patients where that compensation is not very severe, it's very mild discrepancy, very mild curve of spee, very mild crowding, that you can correct by post-surgical orthodontics. Such cases, you skip the step number 2. Skip step 2. You don't go for a pre-surgical orthodontics. You do assessment, you do mock surgery, you perform the surgery. After the surgery, whatever orthodontic corrections need to be done, they are very minor. That can be done after surgery. So you just skip the step number 2. This is a faster approach. If conventional surgery takes around 2 years, you know, starting from assessment to pre-surgical to surgery to post-surgical, it is around 1.5 to 2 years that it can take. So surgery first approach can finish everything in 6 months. Just a broad idea. Okay, but obviously, every case cannot go for a surgery first approach. There are very, very specific indications which are asked again and again in the exam. And you just have to remember that step 2 is skipped in surgery first approach. You just do the assessment and you directly jump for surgery. There is no pre-surgical orthodontics. And what are the indications of surgery first approach? Bas, khatam. This is all that is there in orthognathic surgery. Now, all we have to do is just understand these steps one by one. Few selected questions will come from these 5 steps only. And that is all you have to remember. Nothing here, nothing there, nothing extra. Just these 5 steps and few questions from each and every step. Okay. So first, coming to assessment and analysis. So like I said, you do the pictures, you take the clinical pictures of the patient. Okay. You take the lateral cephalogram. Now this is a lateral ceph. Okay. This is the lat ceph. You can see that rule scale there and it is measured. So you mark your orthodontic points. So this is the, you know, the glabella, the nasion, the ANS, the menton, the gnathion, on all those orthodontic points that you must have read in your orthodontic classes. And this is done for COGS analysis. Now sometimes they said ki kisne diya tha? Who devised the COGS analysis? So that you have to remember. Burstone and Ligan had given the COGS analysis first. Okay, so that is done for all cases that have been planned for orthognathic surgery. All right, I am still waiting. If you guys have any doubts, I have my live chat open here. In case you have any doubts, please keep posting it in the live chat. All right, now this is a PA ceph. PA means postero-anterior. Okay, in your OMR classes, you will know the different kinds of extraoral X-rays that we do. So when the film is placed anteriorly and the X-rays fall from posterior to anterior, from the posterior to the anterior, it is called a PA-CEF because the film is anterior, X-ray is coming from posterior to anterior. So we call it a PA-CEF. Anterior structures will be much more clearer because the film is closer to the anterior structures. If I want my occipital region to be more clear, I will take an AP-CEF. I will take the AP because the film will be closer to the posterior part. So here I am doing a PA-CEF. Okay, the analysis that we do, again I am repeating, is a Grumman's analysis. And it is done for asymmetry cases. Okay, for asymmetry cases, like you can see here that if I start marking the midline, this is my upper third midline, this is my nasal midline, this is my maxillary midline between the central incisors, and this is my mandibular midline. And I can very obviously see that my mandibular midline is shifted. This side of mandible is short, this side of mandible is long. So for asymmetry cases, for planning asymmetries, the PA-CEF is done. Alright. Obviously OPG you can do, we usually do OPG routinely. They are not used for analysis, but like this is the case of gap arthroplasty that is done after TMJ ankylosis. So if you want, you can do an OPG, okay, but it is not used for analysis. Then you will do your cast analysis. You will occlude, you will articulate your cast on the articulator. You will know that, okay, 4 mm I have to take the maxilla up, 4 mm I have to take it back, mandible, this, that, whatever planning you have to do it on the cast. This is the conventional method. Nowadays we have digital, everything is digital. Assessment is done very nicely on the digital platform, and this is what we used to do as PGs, okay? So the blue is pre-op, red is after orthodontics, and then we do all the planning, this much forward, this much backward. And we develop what is called as the visual treatment objective. We know how much maxilla needs to be moved, how much mandible needs to be moved anteriorly, posteriorly, downward, upward, how much cant correction needs to be done, how much genioplasty needs to be done. So whatever planning that you are doing, the conclusion of that planning is called the visual treatment objectives, okay, which is VTO. Okay, and this is my mock surgery. This is how I'm doing my mock surgery, okay. These are actual pictures from my PG times. So this is, one second. Yeah, so this is my articulated cast, okay. Now I know I have to take my maxilla 4 mm up. I will cut my, articulated cast from the anteriorly, from the palatal side, and I will use wax or something to, take it back and fix it there. Similarly, whatever surgery needs to be done on the mandible, I will do that surgery, and I will have a final position of my teeth. Okay, that finally after my surgery is over, this should be the position of my teeth. In that position, I will take a bite of the patient with acrylic, with something that will not deform, not with wax, but with acrylic. And that acrylic bite is what we call as the wafer or splint. Okay, acrylic splint or acrylic wafer or occlusal wafer. Okay, this kind of splint. So that when I'm doing my final surgery, I will do my maxillary movements with whatever calculations I can do. And finally, my maxilla and mandible should sit in this exact position where my maxilla and mandible are sitting in the mock surgery. Alright, so this is the occlusal splint or the occlusal wafer that is produced during mock surgery. This can be asked as an image-based question in your exams. Please note, you will have this image in your notes also. Very soon you will have all the notes of all the subjects, and this image will be there in the notes. Please note that this, record this image in your minds. It is very, very important. This can be asked as an image-based question, that this is an intermediate, appliance that is made before the orthognathic surgery. What is this appliance? So it is an occlusal wafer or an occlusal splint. Okay, very, very important. And it can be made digitally also. Now all the advanced computers have these softwares where you can actually perform the mock surgery on the computer. You don't need to cut the cast and take it back and all of that. You can do the surgery on the computer digitally. You can also show the patient by photocephalometry that if your mandible goes back by 5 mm, this is how you will look. So it gives an idea to the patient also that this is how I will appear, and it gives him some confidence that it's a sudden change of appearance. And since orthognathic surgery is only done after growth completion, okay, please note this point. Orthognathic surgery is done only after completion of growth, because if you do it before completion of growth, you do your maxillary mandibular movements, then growth will happen in the old fashion. Whatever growth is happening initially, again the what structure is not growing, it will not grow, or what is growing excessively, that will excessively grow. So your surgery will fail, your results will fail. So orthognathic surgery, unless it is done for life-threatening surgeries like Pierre-Robin syndrome, for OSA and everything, it is usually done after the completion of growth. So it's a mature patient, it's an adult patient. You can show the patient how you will look after surgery, and similarly you can print the splint through a 3D printer. Okay, so you can use 3D printing, and you can actually 3D print your occlusal wafer. All right, so this can be done digitally, it can be done physically. So these are the two methods of doing the visual treatment objectives. All right, so this is the sequence. We've already discussed the sequence. Just to revise, the first is assessment and analysis. Second is your pre-surgical orthodontics. Once the orthodontics is done, you will do your mock surgery. After the mock surgery, you will do your actual surgery. After your actual surgery, you will do the post-surgical orthodontics. All right. This is the sequence. We've discussed analysis and assessment. I don't need to discuss pre-surgical orthodontics. Just remember, it is done for dental decompensation. To decompensate whatever occlusal compensation has occurred, you do that. We've discussed mock surgery. What is important in mock surgery is the occlusal splint or wafer that is created. Okay, now we come to the actual part, which is surgery. I will not discuss the post-surgical orthodontics also, because it is more of an orthodontic thing. It is just done for finishing or settling of occlusion, for the minor discrepancies that that are left after surgery. Okay, so now we come to the most important aspect, which is surgery. Okay, coming to mandibular surgeries. Okay, so surgeries can be done on mandible, surgeries can be done on maxilla, and most of the times it is a bi-jaw surgery that we do. Okay, to have a stable occlusion, suppose I'm changing my maxilla 5 mm, 6 mm, I might want to do my mandible also to have a balance. Okay, so it can be either a single jaw surgery, mandibular surgery, or maxillary surgery, or it can be a bi-jaw surgery, that is both maxillomandibular surgeries. Now in one jaw also, it can be one surgery or it can be two surgeries. More commonly in the mandible, I can do a BSSO plus a lift, plus a genioplasty. Okay, so in mandible, you can do two surgeries also, like a posterior surgery, like BSSO, VRO, inverted L, whatever, plus a genioplasty. Genioplasty is a minor additional surgery that you can do alone or you can do in combination with other mandibular surgeries. So just make a table with me. I will just give you a list of mandibular surgeries and why we do it, when we do it, and then we will go for individual surgeries. Okay. So the first surgery that we will talk about is VRO. What is VRO? VRO is vertical ramus osteotomy. Simple English, okay? Vertical ramus osteotomy. Osteotomy means cut. Ostectomy means cut and remove. Okay, when there is an infection in the bone and you cut that bone and take it out, it is called ostectomy. When you just give an incision and kind of give a planned fracture on the bone, it is called osteotomy. Okay, so the cut in the bone is called osteotomy. When it is done on the ramus, it is called ramus osteotomy. When it is a straight vertical cut, it is called vertical ramus osteotomy. Simple. Okay, so vertical ramus osteotomy stands for VRO. If you perform the surgery from within the mouth, that means your incision is in the oral cavity, in the retromolar region, you give an extended wards incision and you do all the surgery through an intraoral incision, then you call it an IVRO. Intraoral vertical ramus osteotomy. If you do an extraoral incision, like a submandibular incision here, because it is not very easy to do a VRO from intraorally, okay, but you want to do it because it's a cosmetic surgery and you don't want to give a scar. So it is always desirable to do an IVRO, but sometimes it is not possible to do the surgery intraorally. You have to give an extraoral incision here, raise a flap, visualize the ramus, give a vertical cut in the ramus and then move the mandible. So that is called an EVRO, extraoral vertical ramus osteotomy. Okay, VRO, vertical ramus osteotomy, IVRO, intraoral VRO, EVRO, extraoral. Same surgery, just the incision is different. In IVRO, incision is intraoral. In EVRO, incision is extraoral. What do we do these surgeries for? We do it for large setbacks. If you have to take the mandible back by a large amount, say a 7 mm setback or an 8 mm setback or a 10 mm setback, if you have to take the mandible back by a large, by a large distance, then you prefer the VRO. Then you perform the vertical ramus osteotomy. See, you have, or I have, or anatomists have, labeled it as mandible, overlying muscle, masseter, medial pterygoid, inferior alveolar nerve, teeth. We have separated everything. For our convenience, for our learning, we have separated all the structures, all the anatomical structures separately. That this is bone, this is muscle, this is tendon, this is teeth, this is nerve, this is the neurovascular bundle. God has connected everything inside the body. For God, everything is just one body. He has not kept anything disconnected. If you move a tooth, it is not just that tooth which will move, it is also the alveolar bone, the associated blood vessels, the associated gingiva. Everything will have an effect. Similarly, when you do an orthognathic surgery, if I cut my mandible vertically and if I take it back, it is not just the mandible which is going back. It is also the associated soft tissues which I have to dissect, which I have to cut, which I have to take care of that it should not bleed, it should heal properly, the blood supply should be intact, the nerve should not be damaged. So, it is not just the bone that you are taking forward or backward, upward or downward. It is all the associated soft tissues also. And in mandible, two things are very, very important. Rather, three things are very, very important. The joint, the inferior alveolar neurovascular bundle, and the soft tissues. The pterygomasseteric sling which is there, okay? So laterally we know on the mandible there is masseter. Medially we know that there is medial pterygoid. In the angle region, they both meet and form a sling which is called the pterygomasseteric sling. Now this pterygomasseteric sling, when you take the mandible back or when you take it forward, it is a big roadblock to moving the mandible. Okay, you have to really strip this sling without compromising the blood supply, and it's a big hurdle to your movements. So when you are doing a simple a BSSO or something, this pterygomasseteric sling will be a problem. In VRO, you are able to do the large setbacks because this pterygomasseteric sling is negotiated. Okay, So this is the advantage, this is the indication of doing a vertical ramus osteotomy. Okay, just make these notes, and after that we will go for each surgeries independently. And what are the drawbacks of VRO? That you can't do advancement. Why can't you do advancement? Because if you cut the mandible vertically and take one part anteriorly, there will be no connection between the proximal and the distal part. If there is no connection, the connection is lost. If there is a gap, it is a failure surgery. It will always relapse, it will always fail. The more is the gap between the two osteotomized segment, the better is the outcome of the surgery. Okay, so please write it down. The more is the bony overlap between segments of bone, the better is the stability of surgery. So you can try to be God when you are doing orthognathic surgeries, but you are not God. Correct? Or I'm not talking about you, I'm talking about myself. You know, even when I go and perform a BSSO or a VRO, I have a feeling that, oh, I'm, just acting God and I'm cutting this and do that, but I'm not God. I cannot control the soft tissues. I cannot control what, what kind of relapse can happen. I can only be cautious about it. Okay? So, the more I give a bony overlap, the better will be my stability of surgery, the less will be my relapse of surgery. Okay, relapse means going back to the same position, what it was before surgery. So the less will be the relapse. So in VRO, if I do my setback, okay, if I'm cutting my mandible and doing my setback, the two segments are nicely overlapping each other. But if I do a VRO and if I advance my mandible, the two segments will never even touch each other. So I can't do advancement with VRO. Okay, look at this image now. This is vertical ramus osteotomy. As the name suggests, vertical ramus osteotomy. So this is the lingula of my mandible. This is where my inferior alveolar neurovascular bundle enters the mandible, and it is going to supply my distal segment. Now, whenever you cut the mandible, you create two segments. Okay, this is the first segment. This is the second segment. The segment which has the joint, this is my temporomandibular joint, right? This segment will have my temporomandibular joint. The segment which has the TM joint, which is closer to the midline of the body, that is called the proximal segment. The segment which is middle towards the midline, which is having the TM joint, that is known as the proximal segment. In any mandibular orthognathic surgery, the segment which has the TM joint is called the proximal segment. And the segment which is away from the midline, which has the teeth, or which is away from midline, that is called the distal segment. Okay. Now, in my further lectures, I will use the word proximal and distal. Okay. So this is the proximal segment which will never move because it has the joint. Okay. This segment will never move because it has the temporomandibular joint. You can't move the condyle out of the glenoid fossa. Any movement that you need to do is in the distal segment. Okay. So the rules are, the proximal segment will never move. It is always fixed. The inferior alveolar neurovascular bundle will always be in the distal segment. These are the two rules for any mandibular orthognathic surgery. The proximal segment will just stay there and it will never move. The distal segment always has to have the inferior alveolar neurovascular bundle. Okay, even if by mistake it has come into the proximal segment, you will free it up from the proximal segment and move it with the distal segment. Otherwise, it can come into the, into the new articulation that is formed. It can just get compressed and everything. So you have to free the inferior alveolar neurovascular bundle and move it with the distal segment always. Okay. In vertical ramus osteotomy, which is done for large setbacks, I will do a vertical osteotomy like this. I will take my mandible back. I will slide my proximal segment laterally. I will slide my distal segment medially. Means I will kind of impact my distal segment into my proximal segment. ठीक है, मतलब मैं anterior mandible को posterior mandible के अंदर घुसा दूंगी. I will just impact it there. Okay, the anterior, which is the distal segment, I will just impact it into my proximal segments. Okay, so two proximal segments. If I am doing a bilateral VRO, I will have two proximal segments, one distal segment. I will just impact it medially. So my distal segment will be medial. Distal segment will lie medially. Okay, why? Because the inferior alveolar neurovascular bundle is on the medial side. You have to save it. So to save it, I will have to push the distal segment medially. Okay, so this segment, which is the tooth bearing segment, it will go medially, and the joint bearing segment, which is the proximal segment, that will stay where it is. Okay, it will be laterally. And now once I have done my setback, 7 mm, 8 mm, 10 mm, whatever I have decided in my mock surgery, whatever setback I have to do, I will do that setback and I will fix it either with plates and screws, or I will use just long screws which are called positional screws. Okay, I can use both the things because it's more or less like a fracture. It's a deliberate fracture that you have done, that I have done or you have done, whoever is doing that surgery, and you are fracturing the mandible in a desired direction. You are doing the changes, you are doing the movements, and you're just treating it like a fracture, just putting two plates and some screws and fixing that segment. Or if the overlap is nice, you don't even need plates, you can just put 3 or 4 long positional screws and fix that position along with the occlusal splint. Okay, so this is how we perform the vertical ramus osteotomy. I'll quickly share you one case from my PG times. This was a beautiful, handsome boy with a class 3 mandible. You can see in the lateral ceph that the mandible is very, very prognathic. We needed to do a mandibular setback, which was a large amount of setback. We did the cephalometric tracing. We performed the surgery. And, this is all the pre-surgical phase. This was an extraoral vertical ramus osteotomy. So there is an extraoral cut. Okay. You can see the ramus. If you can visualize that this is my submandibular region, this is my ramus, which is cut vertically. I am taking my mandible back. I am fixing it with positional screws bilaterally. I am putting my sutures. I am fixing my occlusal splint here. This is my occlusal splint, or my occlusal wafer, to get the desired position of my mandible. कि mock surgery में I have decided 10 mm setback, तो 10 का 11 नहीं होना चाहिए, 10 का 9 नहीं होना चाहिए, it should be 10. So this splint will fix the position of the teeth and keep it there so that I have exactly 10 mm setback as I have planned in my mock surgery. Okay, and you can see that in the post-op OPG, you can see 2 screws here, 2 screws there. And this is how beautifully we could change the profile of the boy from a class 3 profile to a straight, nice profile. Boy is happy, I am happy, you also become happy because now you know how to do a vertical ramus osteotomy. Okay, so this is the first mandibular surgery that we've talked about. Okay, it is called the VRO. It is done for large setbacks of the mandible, and you can't do advancement with it because it will create a gap between the teeth, between the segments of bone, and the surgery will relapse. Okay. The second surgery that we will talk about is, if there are any doubts about VRO, please post your doubts in the chat box in the YouTube link. Inverted L or C osteotomy. Now people thought that instead of giving a vertical straight cut, let us put one horizontal and one vertical cut, so that even if you do advancement, there will be some overlap between the bones. Okay. So that brought us to inverted C or L osteotomy. Why L? This is L and this is inverted L. Okay, this is the inverted L osteotomy. Okay, and if you curve it like this, instead of giving sharp cuts, if you just curve your cut like that, so it becomes a C osteotomy. More or less, the function is the same, the indications are the same, everything is same. If you give sharp cut, it becomes L osteotomy. If you curve your cuts, it becomes a C osteotomy. Okay. So what is the indication? So instead of putting a long vertical cut on the ramus, it is giving one horizontal ramus cut and one vertical cut. So if they ask you which orthognathic surgery of the mandible has one horizontal cut and one vertical cut, so you know it is the inverted L osteotomy where there is a horizontal cut on the ramus. Where is the cut? Again, this is our lingula, just above and just posterior to the lingula. So you will start it just above the lingula from the anterior ramus. You will go posteriorly, not full throughout the posterior. You will stop just posterior to the lingula. And from there you will drop a vertical cut like this. And it becomes a inverted L osteotomy. Now what is the advantage? The advantage is that even if you have to do slight advancement, it is possible because there will be some overlap here. So indication for inverted L osteotomy is open bite cases. We use inverted L osteotomy in open bite cases. So when there is an anterior open bite, you do an inverted L osteotomy, you close the bite. You can just rotate your distal segment like this and you can close the bite. So there will be gap here on the lower side, okay, but there will be contact on the horizontal cut. Even if there is gap in the lower segment, it is okay because you will have overlap in the horizontal cut segment here in this region. So there will be no relapse. So the indication, specific indication for inverted L osteotomy in your table, you can write it down, is open bite cases. What are the drawbacks? You can't do large advancements. It is not really indicated for advancements. It is basically indicated for your open bite cases. Okay, when you have to do slight rotation of the mandible, also only for the anterior or the distal segment. Okay, next we come to what is called as, so Shruti is asking me what is the maximum extent of setback using VRO. Shruti, this is very, very variable depending on the size of the mandible. Okay, if it is a small, short height girl with a small mandible, the width of my mandible maybe is 10 or 12 millimeters. So that will decide how much I can take it setback, how much setback I can do. Okay, if it is a small mandible, I can do small movements. Against that, if it is a large patient, a bodybuilder, like imagine Khali. Okay, so Khali has gigantism with a mandibular class 3 profile. He has a big mandible of say 20-22 mm. If in that patient I have to do a setback, I have the advantage of having a big bone, having large movements possible. So in that case, I can give my VRO, I can take my mandible to even say 12 mm setback. Okay, so how much setback, how much advancement is possible will depend on the size of the jaw. It will depend on the size of the mandible and it varies between patients. It will never be asked to you as a question in exam that what is the maximum extent of advancement or setback possible. On an average, you can say around 10 mm, 8 to 10 mm. But actually, clinically, practically, it depends on the size of the mandible. Okay, a small mandible, less movements possible. Large mandible, more movements possible. Is that clear? If it is clear to you, please say a yes to me in the same chat box and so we can proceed forward. Okay, so the next surgery that we can do in mandible is the SSRO. Okay, now just make your notes. Wherever you're writing, you can write SSRO/BSSO. Okay, we will go to the surgery first and then we will finish the table. Now till now, you have seen either it is a vertical osteotomy or it is a vertical plus horizontal osteotomy. Okay, so in inverted L, there was a horizontal plus vertical. In VRO, it was a vertical osteotomy. Now in BSSO or SSRO, there is a sagittal osteotomy. Okay, so there is a horizontal osteotomy plus there is a vertical osteotomy plus there is a sagittal osteotomy also. Okay, now whoever, Mr. Shujat was the first person to describe SSRO, and I am hats off to that person to think it in this fashion, that you give a sagittal cut in the mandible. Whatever movement you do, you will always have a bony overlap. Imagine the sagittal suture. So this is your sagittal suture on the skull. This suture running between the two parietal bones. Okay, so this is your coronal suture, this is your sagittal suture, right? It's an antero-posteriorly running suture. So just like that, when you split the mandible in between through the body of the mandible antero-posteriorly, it becomes a sagittal osteotomy. Now, if you directly try and cut the mandible sagittally, it can just fracture like that. So to prevent that fracture, what we put is the stop cuts. Okay, so what we do is first we do the medial horizontal cut. Here on the medial side of the mandible, we put a horizontal cut on the ramus like this. Okay, now on the lateral side, so if I'm talking about this side, let me tell you here. On this side, medially you have done a horizontal cut, not a full cut through both the cortices, a single cortex cut. Okay, one cut only through the medial cortex, not through the lateral cortex. The lateral cortex is intact. You can see here the lateral cortex is intact. Only through the medial cortex till the medulla, you are doing this horizontal osteotomy. Now what you do is laterally, on the lateral surface, you put this vertical stop cut or a vertical osteotomy. Okay, so you've put a medial horizontal osteotomy, a lateral vertical osteotomy. Now connecting these two, you will do a sagittal osteotomy. You will cut your mandible through the body of the mandible, through the cancellous region of the mandible, which is your sagittal cut, your antero-posterior sagittal cut. And this is why this procedure is called sagittal split ramus osteotomy, SSRO. This surgery is called sagittal split ramus osteotomy. Most of these osteotomies are done on the ramus. Vertical ramus, inverted L is also on the ramus. Now a part of this cut, the stop cut, is on the body region of mandible, but most of this cut is on the ramus. So we call it a sagittal split ramus osteotomy or SSRO. Usually, we do this surgery bilaterally. If we are doing VRO, we are doing a bilateral VRO. If we are doing inverted L, usually we are doing a bilateral inverted L. Similarly, when we are doing a SSRO, we do it bilaterally. So the more popular term is BSSO, means bilateral sagittal split osteotomy. Bilateral sagittal split osteotomy. Okay, it is such a beautiful procedure that this is your proximal segment, the segment which has bone. This is your distal segment, the segment which has teeth. Even if you do advancement, even if you take the distal segment forward, there will be good overlap. Even if you do setback, there will be good overlap. Even if you do open bite correction, that is rotation of the mandible, there will be good overlap. Even if you take the mandible down, there will be good overlap. Even if you take your mandible up, you can just do some additional cuts here and take the mandible up. There will be very good overlap between the two segments of bone. That means BSSO is the workhorse of mandibular orthognathic surgeries. All kinds of movements are possible with BSSO. So come back to your tables wherever you're making these notes. Write it down. BSSO is the workhorse. It's a repeat question of NEET, that which of these surgeries is the workhorse of mandibular orthognathic surgery. So your answer will be BSSO. All movements are possible. All movements possible. Okay. I am not saying that you can do a 20 millimeter advancement with BSSO. Whatever is the scope of that mandible, of that size, of that patient, in that scope, all the movements are possible. You can do advancement, you can do set back, set up, set down, rotation, asymmetry correction, open bite closure. All movements are possible with BSSO. That is why we call BSSO as the workhorse of orthognathic surgery. Okay. Just quickly, we will just see two more surgeries. And then I will make diagrams so that you can also understand. So if you have to make in your notes, if you have to make diagrams, this is how you make the mandible. Okay. So this is my lingula, from where my inferior alveolar neurovascular bundle will enter into the mandible. Okay. So this is the lateral aspect of my mandible, and this inside is the medial aspect. So if I have to draw a VRO, this is for all of you to make notes. If I have to draw a VRO, I will put a cut like this. From the sigmoid notch to my angle of mandible region, posterior to the lingula. This is my vertical ramus osteotomy. If I have to do an inverted L osteotomy, again I will draw my mandible. This is my lingula. Superior and just posterior to the lingula, I will make a horizontal cut. Then I will convert it into a vertical cut. So this is my inverted L osteotomy. Okay. And if I have to make a BSSO or a SSRO, this is my mandible. This is my lingula. Medial side, I will do a horizontal cut just above and just posterior to the lingula. Just above and just posterior to lingula. I will put my medial horizontal cut. Why am I doing this? So that I can save the inferior alveolar neurovascular bundle from injury, and I can take this neurovascular bundle into the distal segment, which is the rule. That is a rule. We have to take the inferior alveolar neurovascular bundle into the distal segment. So that is the first cut. Then distal to my second molar. This is my second molar tooth. This is my first molar. This is my second molar. Distal to my second molar, I will put a vertical cut. Okay. That is my vertical stop cut on the lateral aspect of the body region of mandible. So this will prevent, if when I do my sagittal cut, this will prevent the sagittal cut to, go haywire and cause a bad fracture, cause a bad split. So this vertical stop cut is very, very important for that. And then I will do my third cut, which is basically connecting these two cuts, which is the sagittal cut. Which is the sagittal cut, or rather the sagittal split of my mandible. Okay. Now, very important instrument that we use for the sagittal split. After I've done my osteotomy, I need an instrument to split these two bones. So the instrument that I use here is a Smith spreader. I will show you pictures. You can use a T spreader or a Smith spreader to split your mandible into the proximal and distal segment. So this is how you have to draw your osteotomies. The next mandibular orthognathic surgery that we are going to talk about is body osteotomy. Okay, again the indication is same. It is limited indication just for open bite cases. or some asymmetry cases. Just like the Burns case that I showed you initially, that patient's posterior occlusion was absolutely normal. Just the anterior teeth were flared or the anterior jaw was flared because of the burns. So in that case, I can go for a body osteotomy. The drawback is that it has limited limited use only in these indications. So what I do is, in body osteotomy, yeah, so this is the perfect case for a body osteotomy. The cant is straight, the occlusion is straight, posterior occlusion is normal, just the anterior occlusion is poor. So I will take one tooth out from both sides. I will take one tooth out from both sides. I will create a space for osteotomy. I will put cuts in the mandible and I will close the open bite. Okay, in this space, I will take the mandible back, I will take it up. Whatever movements I need to do with the anterior segment, I can do by doing a body osteotomy. And then I will fix it like a fracture. We all know that in body fracture, you have to use 2 mini plates. So you fix it with 2 mini plates on both sides. So this is the body or the segmental osteotomy. Okay, body osteotomy is also called segmental osteotomy because here you are moving just one segment of mandible superiorly, or maybe there is an asymmetry. So to correct that asymmetry, you can do more resection on one side, less resection on the other side, and correct that asymmetry. Okay, so for open bite and for asymmetry correction, you will use your body osteotomy. Okay, the last type of osteotomy is the subapical osteotomy. Purposefully, I have not put it there because it's not that important. In subapical osteotomy, it is similar to body osteotomy. You basically make that cut, and instead of taking the whole bone, you put one more cut like this. So this segment of bone, so you've done this cut, you've done that cut, and instead of moving the whole bone, you let the basal bone be there and you just cut till here, just below the apex of the teeth. Okay, basically you cut just below the apex of the teeth. You leave the basal bone of mandible intact, and you can put some bone graft there in that space which is created between the basal bone and the segment, and you can just move the tooth-bearing segment of bone. Okay, so osteotomy which is done in the body region just below the apices of the teeth, that is called subapical osteotomy. Not very popular, hardly it is used nowadays. It is best to do a BSSO or a body osteotomy. Rarely we use subapical osteotomy. Whenever there is a discrepancy, usually we involve the basal bone also. Okay, so this is just for the theory's sake, just to complete the list. There is one more osteotomy which is called the subapical osteotomy. Okay, now there is one question again from Shruti. BSSO involves ramus and body or ramus? In one of the questions, answer was given only. See, basically all the osteotomies of the mandible are ramus osteotomies. When you divide the proximal and distal segment, you basically divide it from the ramus. Just the vertical stop cut is on the body. That is just to prevent the cut from spreading to the body region. So technically speaking, these are all ramus osteotomies. Okay, sagittal split ramus osteotomy. Of course, there is a vertical cut in the body region, but that is just to prevent the extension of the ramus cut to the body. So your answer will be ramus. It is a ramus osteotomy. Basically, you are putting the cuts in the ramus. What you are splitting is the ramus. So it is a ramus osteotomy. This is a body osteotomy. This thing is a body osteotomy. Okay, so this was Shruti's doubt whether BSSO will be called a ramus osteotomy or a ramus plus body osteotomy. Now here you have to be very careful about the language of the question. If the examiner is asking you that the cuts which are put in BSSO are placed in the ramus, body, both or none, in that case your answer will be both, because your osteotomy or your cut is basically in the ramus also and in the body also. So if the language of the question is such that the osteotomy cuts in BSSO are placed, then your answer will be both ramus and body. If the question's language is that BSSO will cause a split in which segment of mandible? Body region, ramus region, angle region, symphysis region. In that case, your answer will be ramus region. What happens is, these are basically recall questions. Student remember the questions partly and then they come back and then books are made and everything. So the language of the question is not recalled properly, which is why we tell you, don't mug up the answer. Don't mug up the question. Understand the concept around the question. Then you will be able to answer in your main exam very, very nicely. आपको समझ आ जाएगा कि एग्जामिनर पूछ क्या रहा है. वो ऑस्टियोटमी कट के बारे में पूछ रहा है या वो स्प्लिट के बारे में पूछ रहा है. If the examiner is asking about the split, it will be a ramus split that you're doing. If the examiner is asking you where you are putting your osteotomy cuts, then answer will be in the ramus and in the body. Okay, Shruti, I hope that is clear with you. Sujal, we can talk about the miscellaneous things after the live class. Right now, our discussion will only be about the live class. Okay, Shruti, please tell me a yes if you understand this concept, if this answering concept. Okay, so this is the fourth type of osteotomy. You can make your notes. After body osteotomy, you can also do the subapical osteotomy. Again, very limited indications of, single or few teeth which are not in occlusion. Very limited uses, very limited indications. Okay, all right. So these are the mandibular surgeries that can be performed in patient depending on what is the indication. Okay. This is a ramus surgery, this is the ramus surgery, this is the ramus surgery, this is a body surgery, this is also a body surgery because teeth are in the body region. And one last surgery that you can add here, after which we are going to take a short break. The last surgery that you can add here is genioplasty. That is the last mandibular surgery. It is basically a chin surgery. You just put a cut here like this. Canine to canine, just in the symphysis region, parasymphysis region, just put a cut like this. Take the chin forward, take the chin backward, take the chin down, take the chin up. It is again a very free surgery. You can do it alone. You can do it in combination with VRO, with inverted L, with SSRO. Okay. It is basically to move the chin in any direction. It's a simple surgery. It can be done under LA. I've done it on the dental chair. So it's a relatively simpler surgery. Just putting an intentional fracture from canine to canine anterior to the mental foramen. Put an osteotomy, take the mandible anteriorly, take the chin anteriorly, posteriorly, downward, backward. You will think how downward? You can put bone grafts and take it downward. It is quite stable. Chin surgeries, you can use bone grafts. You can use double sliding genioplasty for, further advancements and all of that. Okay, so with that, we have covered all the mandibular orthognathic surgeries. Coming back to BSSO, which is very, very important. Most of your questions will be on BSSO. After you have done your advancement, your setback, you can see here the distal segment is advanced. You can fix it with plates. You can fix it with positional screws, just like we had discussed before. Okay, you can fix it with positional screws, or you can fix it with plates and screws. Positional screws are just long screws, long bicortical screws, which you can, penetrate through both the lingual buccal and the lingual cortex. So long screws, we can just finish or fix the position of the changes that you have done. Okay. Now coming to that instrument which I was talking about, this can be asked again as an image-based question. This can be asked as an image-based question. Now this is a T spreader and this is a Smith spreader. Okay, so basically you just split your mandible. After you have done your cuts, you need something to split it, right? So for that, this is how the prongs look like. It's a 3-pronged instrument, 2 prongs together and 1 prong to separate the distal segment. So this is how a Smith spreader looks like. We will have all these pictures in the notes. So don't worry, these image-based questions will be covered when you have your notes. All right. Now, what are the instruments that can be used to do the osteotomy? We have discussed the different osteotomies. Now, what are the different instruments or equipment that we can use for osteotomy? Okay, so we can use 3 instruments. First, we can use the oscillating saw. Okay, so this is the oscillating saw. It will oscillate like that. You know, you can see this motion. There are different kinds of blade. There is a fan blade, there is a circular blade. Depending on where you want to put the cut, there is. So this instrument is called the oscillating saw. I've used this clinical picture also where a buccal stop cut is made using this oscillating saw. Okay, so this is the first instrument that you can use. It is the oscillating saw. Second instrument which you can use is the micromotor and burr. It is the same micromotor and burr that you use for your wisdom tooth removal. Okay, commonly you have seen it in your oral surgery departments that micromotor and burr is being used for your buccal guttering, for your tooth splitting. Okay, that same burr and micromotor, sometimes you have angulated handpieces. So you can use those, like this is an angulated handpiece, this is a straight handpiece. You can use these instruments also to make your osteotomies. Now the disadvantage with these 2 instruments is they cut everything. Whatever will come into contact, whether it is bone, whether it is muscle, whether it is nerve, whether it is blood vessel, it can cut everything. These are sharp bladed instruments or burrs, and they can cause injury to the soft tissues also. So you have to be very, very careful. The surgeon has to be very, very careful when he is cutting the bone, he is making those osteotomies to, safeguard the soft tissues so that they are not cut. Or you can use what is called the piezoelectric instruments, the piezoelectric saws. So this is how a piezoelectric saw is used. It's a very, very commonly asked image-based question, especially in the INI-CT exam. These are the different blades of a piezoelectric saw. So the beauty of piezoelectric saw is, even if it comes in contact with a nerve, even if it comes in contact with a muscle, it will not injure the soft tissues. It will only cut the bony tissue. It will only cut the hard tissues. So the very big advantage of piezoelectric saw is it is soft tissue sparing. It will not injure the soft tissue. So if your department is rich enough to afford a piezoelectric saw, then you will be fortunate to see a piezoelectric cutter in your department. You can use it for your TMJ ankylosis surgeries where you have to preserve the internal maxillary artery. You can use it for orthognathic surgeries. You can use it for third molar removal, wherever you want to use it. The only disadvantage is that it's a little slow. Disadvantage nahi bolungi, I'll call it a drawback, that it's a little slow. It cuts the bone very, very slowly as compared to the micromotor burr or the oscillating saw. So the cutting of the bone is slow, but it is soft tissue sparing. It will never cut the soft tissues. So it is very, very advantageous in that way. Okay, so these are the 3 instruments or equipment that we use for all the osteotomies of maxilla, mandible, wherever. Okay. And this is the genioplasty that I was talking about, just a canine to canine cut. You can see in this image, it is an old image of the old times where fixation used to be done with wires. Now fixation is not done with wires, no wire osteosynthesis. You use usually bone plates. These kind of chin plates are available very commonly in the markets. Or you can bend your mini plates and form the chin plates. Okay. These radiographs are also commonly asked in exam as image-based questions. So please register these radiographs in your mind whenever you see that there is an osteotomy in the chin region. Okay, you can nicely see this radio opaque, this radiolucent line here between the red lines that I have marked, that radiolucent line. So you know that it's a chin osteotomy. So this chin osteotomy is called a genioplasty. Image-based question is asked on this frequently. They will give you a lateral ceph like this or a PSF like this, and they will ask you what surgery is being done or what surgery has been done in this patient. So the answer will be genioplasty. All right. Okay. So before coming to this table, you guys have already made your table. You know what is VRO, what are the indications, that it's done for large setbacks. Again and again, guys, I'm revising the same things because this is all you have to know. This is enough for being in the top 10 of NEET, in the top 10 of INI. If you remember this much from orthognathic surgery, you will be able to answer 90 to 95%. I will not say 100% because, examiner is can ask you anything, but you will be able to answer most of the questions. Okay, so VRO ho gaya. Inverted L is for open bite cases. BSSO is the workhorse for all movements possible. Body osteotomy is mainly for asymmetry, and more than asymmetry, it is for open bite. And genioplasty is for your chin corrections, chin movements, okay? Chin movements in all directions. Okay, so now you know all the mandibular surgeries. Just a little complication that I want to discuss. One complication that can happen, many complications can happen with different surgeries, okay? VRO can cause a nerve injury, BSSO can cause a bad split. Any complication can happen, but one complication which is academically important, which is asked to you in exam, is this one, which is called as condylar sag. Especially with your Ramos surgeries. Now, when you are doing your BSSO or VRO, you are using the splint to fix the position of the distal segment. Now, the patient is under GA. He is lying like that. He is under general anesthesia. And you all know that under general anesthesia, all the muscle tone is lost. The patient does not have any reflexes. The patient does not have any muscle tone. So, the lateral pterygoid, the temporalis, the medial pterygoid, masseter, every muscle has lost its tone. So, what can happen is this condyle, which is normally fixed into the glenoid fossa by the muscle tone, that condyle can sag. That condyle can naturally lose its, position within the glenoid fossa. So, suppose this is my temporomandibular joint and this is my glenoid fossa, this is my joint. This is the position of my condyle normally. This is how it should be normally within the glenoid fossa. Under GA, what can happen is, instead of being there, the condyle can sag like this. Because now you have cut the mandible, you have done a VRO, you have done a BSSO. This segment you are moving here and there, and this segment you are not taking care of. So this segment will get angry, yaar, mere ko to dhyan hi nahi diya. So let me show some complications. So this part of condyle, it is devoid of its, it is devoid of the muscle tone. It is devoid of the, normal position that it should be, and it comes a little down. So what happens is, if you don't take care of this condylar sag and you fix your bone plates by moving the distal segment, if you fix your bone plates like that, when the patient will come out of GA, when he is awake, when he is alert, he will take his mandible back to the centric. He will take his condyles back to the normal position because that is how he is born. That is how it is. And that will disturb your whole surgery's occlusion. That will disturb whatever movement you have done. Suppose the condyle has sagged by 3 mm. So that 3 mm movement disturbance will be there in your final fixed position. So that is the problem with condylar sag. Okay, so what you have to do is, before you put your plates, before you do your fixation, many instruments, many equipments, many methods कि चलो कोरोनॉइड को जाइगोमा से चिपका देते हैं और ये कर देते हैं वो. Many methods came up to prevent condylar sag. The simplest, the most popular, most accepted method is thumb pressure at the angle of mandible. This is most widely used, most popular and best, simple, easiest method. Simply just put a thumb pressure in the angle region so that you can place your condyle back into the glenoid fossa. If the surgeon is putting the plate, you can ask the assistant that please put the condyle back into the fossa. In that, fixed position, in that restored condylar position, the surgeon can put the plate. So that will prevent the condylar sag. So 2 questions come up from that in the exam, that what is the complication that can happen in the proximal segment. In the proximal segment, when you're doing a BSSO, what can happen? Condylar sag can happen. The second question which comes is, what is the best method or the quickest method or the most commonly used method? All the books have mentioned many methods. The simplest, easiest, best method is to just use thumb pressure and to place the condyle back into the fossa before fixing your movement, before fixing your distal segment after movement. Okay, so that is all about condylar sag. So with this, we have finished all the mandibular surgeries. We have finished the basics of orthognathic surgery, the steps of orthognathic surgery, the indications, the drawbacks of each mandibular orthognathic surgery. We will take a quick break of, it's 7:35, we will take a quick 10 minutes break, and 7:45, I will meet you again with maxillary orthognathic surgeries, okay? Another 1 hour and we will finish maxillary surgeries, and then we will quickly see the surgery first approach. All right, so let's take a quick break for 10 minutes and we'll see you at 7:45 sharp, okay?